topic is redefining flexor tendon outcomes, standard surgeon therapist protocol for superior functional recovery. Our knowledge and experience is limited because the incidence is very rare of flexor tendon injury and repair. We should always remember Hippocrates, Gallium, Avino. Before 19th century, they did the treatment of the flexor tendon injury. Dunel, prior to 1960, described no man's land. Kinnert and Bardan in 1960 described primary repair using modern microscope and technology. In the past 25 years, more scientific research has advanced our every aspect of flexor tendon repair and injury, including repair of the sheath, and we are waiting and updating our future knowledge with AI, robotics and 3D technology, which will improvise and revolutionary technology from diagnostic to 100% protocol. Lot money controversy exists still today even after this much advancement, but I will describe and restrict myself to benefit of post-operative update motion protocol, which will revolutionize the results of the treatment. Our goal is primary repair of the injured tendon within the sheath, restoration of the satisfactory digital function. Despite modern advances in surgical precision, good results and outcome following FTR is not uniformly obtained globally because of inevitable scar formation that interferes with the smooth gliding mechanism within the flexor tendon sheath, which is to be improvised. The common prevalence of failure are adhesions, stiffness, rupture, major cause being delayed or improper immobilization, lack of standardized integrated protocol between surgeon and therapist. As the bone healing, we know the tendon healing, primary or increasing healing by the tenocytes within the tendon, no scar, adhesions, free of gliding and good range of movement. This is the ideal repair which is difficult to achieve. What we are achieving is secondary healing stimulated by surrounding synovial fluid and inflammatory cells, just like callus in bone formation. This is implicated in the formation of scarring and adhesions causing stiffness and destroying our result. Lot many factors affecting the tendon healing and adhesions are there, ranging from type of severity of the injury, age of the patient, surgical technique, expertise and OT setup. But the post-operative motion protocol is very important. Smoking, alcohol, addiction and comorbid condition delays and destroys our results. Standardized surgery improves the technical repair and strength of the repair tendon over decades, and this has encouraged surgeons to learn and adopt early rehab protocol to improve the functional outcome periodically and improve the tendon glide and reduce complication due to stiffness of adhesions and rupture, avoid adhesiolysis and tenolysis. The surgery alone is not sufficient. Rehabilitation variably affects outcome, and there is need for biomechanically strong surgical repair, early control mobilization, initially passive, assisted active and then active mobilization. The surgeon therapist coordination is equally important. Our study design included the study group and control group. In the study group, we mobilize aggressively from day one. In the conservative group, the initial immobilization was done, or after 4 to 6 weeks mobilization was done. Study group included 48 patients and the control group 38 cases with the conservative management. Acute injury cases were 21 in study group as compared to 18 in the control group. Late injury cases were 27 upon 20 cases. Between the two groups, study and control group, 48 and 38 number of cases, we already decided immobilization was not done in the study aggressive mobilization group. And the mobilization in the aggressive mobilization group was started in 24 to 48 hours, whereas in the control group it was started after 3, 4, even sometimes 6 weeks, depending upon the strength of the repair. So we all know the basics of this flexor tendon repair. The timing of repair is more important. It should be performed within 2 to 3 weeks. Delayed treatment leads to difficulty due to tendon retraction and then deterioration shortening after several weeks. And if the wound is infected, repair is still delayed. But ideally, normally repairing flexor tendons should be done within 24 to 72 hours to minimize the adhesions, tendon retraction, defect tension, along with gapping at the repair site and joint stiffness. The ideal surgical technique, it should be a strong gap resistant repair, atraumatic technique. Sutures should be strong enough to tolerate forces generated by early control active motion protocols to prevent adhesion, smooth glide to allow. Six-strand core suture repair is essential for early active mobilization. Circumferential epitendinous augmentation should be done at laceration site is sufficient, and no benefit of adding core suture is needed. The magnification loops are many times sufficient, which we are accustomed to with. Avoid sheath repair to minimize the bulk. Minimal interference with the tendon vascularity by atraumatic technique. An intraoperative glide assessment test is very essential to get a better result and early mobilization. Partial control release of the pulley fibers only when required. Otherwise, preserve majority of the pulley integrity. The advantage being it allows smooth tendon passage, reduce the bulk at the repair site, and improve the tendon glide. But the suture should be pulled taut to facilitate tendon compression, just like bone compression. Before tying the knot, the suture is carefully scissored to take the slack out and compress the tendon ends. This is very important for early mobilization, just like compression, plating in bone and then early mobilization. Preloading the repair to prevent the gap formation. These are different suture techniques, but we should do strong repair. This is wide array flexor tendon repair. We employed in some of the cases under local anesthesia, no communicate, no sedation. It allows intraoperative assessment for repair gaps by getting away patient to actively flex the rigid, and reduces the need for post-op tenolysis by assessment of the repair will fit through the pulleys. Allows on-the-spot debulking of the bunched repairs and allow gliding test within the operative procedure also. It facilitates post-op early active mobilization and best for surgery motion protocol integration. Even patient can understand and simulate the movement what he has to do post-operatively. So this is indicated particularly young cooperative patients. And most important is tensioning of the tendon. Remember, we should maintain the finger cascade. Setting the tension graph finger cascade is important. Fingers fall into semi-flex position slightly less than the ulnar neighbor, allowing estimation of the tension. Even after testing the tension and distal stump repair, one most important practical tip is pin closure on the distal end of the finger to be done first, and then do proximal final suturing the tendon and skin closure. This is to avoid the tug of war in a fixed flex finger when you are suturing the skin. The balance of the forces gives the success. Tendon glide is most important, needed to prevent the adhesions, maintain the excursions, and biomechanical integrity of the suture maintained by pulleys, prevent bow stringing and ensures efficient finger flexion. Outcome measures, we followed up with patient regularly, weekly, and then 3 months and 6 months. The criteria of the outcome were total active motion, grip strength, prehension, return to work, and complication if any. Control and conservative protocol group 3 to 4 weeks, immobilization is not done. In the study group, mobilization in split with day 1 mobilization was started. Technique that allows for early 24 to 48 hours and aggressive mobilization protocol is very essential, which will allow the active flexion, preferable because stretched tendons heal faster, gain tensile strength more rapidly, and have fewer adhesions, enhance the tendon nutrition fluid development, and result in better excursion strength and function as described by Govind. Results of aggressive protocol are superior to previous more conservative protocols. These are various protocols. Aggressive vision. One is the cleaner splint, where active extension with a rubber band flexion. Patient actively extend their fingers into dorsal blocking splint, and there is controlled passive motion. Fingers pulled passively back into the flexion. This shows superior results with primary repair versus delayed grafting. Mayo Clinic synergistic dynamics tenodesis splint, where the wrist motion can be changed and improve excursion with the wrist extension 45 degrees, a dynamic splint, And decreased tension at the repair with the wrist extension gives better and early healing with early mobilization. This is suitable in younger patients and those patients who have been grafted by tendon. There are various assessment scores, Boy's outcome scale based on the fingertip flexion measurement from palm, American Society for Surgery of Hand ASS flexor outcome based on the total active motion, less the excursion, deficit and various grades have been described. But the most accurate assessment tool is the Strickland modification of ASSH, which only considers motion of DIP and PIP motion only as digital flexors, not the primary metacarpophalangeal flexors. There are various grades of the results. Our assessment score in ESIS, where lot many factory accident and injury cases come, the range of movement, power grip strength achieved, resumption to normal duty number of days or weeks, and permanent disability few cases. We presented a paper at American Academy of Orthopedic Surgeons on mobilization of hand under wrist block anesthesia, and this technique was also helpful in early mobilization of the tendon repair cases. These are the clinical functional results between aggressive study group and conservative control group. The immobilization was started in aggressive group in the day 1. The return to work was 9.5 weeks in aggressive group as compared to conservative control group 13.5 weeks. Adhesiolysis was required in 6% in study group and 13% in the conservative control group. There was no rupture or low complication rates as compared to the conservative group. Function was excellent, 81% in the aggressive mobilization group as compared to 65% in the conservative group. Mean TAM was 85% of the opposite hand, whereas in control group it was 65%. Grip strength was 88% as compared to 68% in the conservative group. The protocol adherence is very important for better outcome. Improved tendon glide reduces the stiffness, lower complication, surgeon therapist integration improve the ultimate successful outcome. This is one example where the patient came after 2 years. We did flexor tendon graft of the ring finger, and this was the result at the end of the 4 months. Full flexion, full power, and DIP and flexion were also achieved. So restoration of satisfactory digital function after flexor tendon lacerations is the aim, but one of the most challenging problems because it is a rare injury and our experience is less. Over the last several decades, advanced research and experience in the treatment of flexor tendon injuries, multi-strand repair, good strong construct have resulted in improved patient outcome. But even in the best of the hands, some patients develop stiffness and poor function of a digit after flexor tendon repair, even if we strictly follow the protocol. But early active mobilization protocol, this improves the glide, reduces the adhesions, thus integration gives predictable excellent result. So surgery alone is not sufficient, continuum of the care motion protocol is important, integration between surgeon and therapist is the key to the success. In future, vision about AI can predict rupture, adhesions risk, personalized rehabilitation, motion tracking, via variables, predictable outcome, and 3D preoperative planning, 3D screens, biomechanical simulation, faster recovery, and robotics can control mobilization, real-time feedback for individual improvement, and registry later. So predictable excellence from repair, recovery, and full flexion in the future we will get with this. So standardized surgery protocol is equally important, and early mobilization is essential. Surgeon therapist integration is the key. Flexor tendon repair success is a timely repair, teamwork, surgical technique, and timely rehabilitation. It is not a procedure, it is a coordinated continuum of the care. So you are all welcome to India, Ahmedabad for academic feast in December, first week, IOCON 2026. I welcome you all for your presentation, for any academic work. You can come and enjoy the city of Gujarat, who is the native land of the Narendra Modi, who is our Prime Minister. Thank you all for kind listening.
Prof. Govind.
Yeah.
Thank you, Prof. for your profound and excellent presentation. You are one of my mentors. Very great surgeon. So your study proven that actually the early aggressive mobilization is superior compared to the conservative mobilization. My question is it during the mobilization any difference between planet or Durant methods? Is my first question.
First and basic is the early mobilization.
All right.
As soon as the patient is out of anesthesia, you start mobilization. It will be support to the repair tendons. This is one thing. Initially passive, then assisted active, and then active mobilization. Even in elbow cases, fractures, in children, we never immobilize in plaster. We give slab, and then patient come for dressing after 4 or 5 days. We ask him to mobilize. Even a small child, we mobilize. If our repair is strong. Of course, conservative treatment in plaster is different, but any surgery of the elbow, we never immobilize, irrespective of the age group, irrespective of the fracture pattern. So same protocol is employed in the flexor tendon injury. If the repair is very strong, then there is no problem.
So we start with the passive Durant method first, and then the planet, we put the spring there, right?
Yeah.
Yeah. So together.
Everything combined.
Combined.
Yeah. And when patient come from dressing after 5-7 days, release everything, start gentle mobilization in our presence.
Right.
And also the physiotherapist will take care of the rest of the things.
Yeah. And second question, Prof, regarding the suture, you mentioned that atraumatic, we use frictionless.
Technique is atraumatic.
Yeah.
Technique is atraumatic.
The suture?
Suture can be anything, whatever is suitable. Yeah, it can be even proline, or it can be ethylon, or whatever you synthetic you can use. But it is better to use non-absorbable.
Non-absorbable.
Yeah, it is better.
Okay.
And see, the problem is if the note is outside, then it will lead to adhesions. If note is inside, it may lead to delayed healing. So we have to balance depending on the tendon injury. Our tendon we have to reset to get what length is required. These are all important parameters. It should be decided on table only.
I see. So as long as it is non-absorbable, any suture will be good.
Yeah.
Okay. No need like modified Kessler, modified Baker.
Whatever suture technique you are acquainted, but it should be atraumatic. Its strength should be enough to mobilize it.
Okay.
Suture is not important. Technique, whatever you have adopted, you can continue the same and improvise the technique to allow early mobilization.
No problem.
But you're not using a high tensile strength braided suture like fiber wire, right? You're using like proline or.
Recently, new fibers are available for the tendon repair, just like this.
They're very abrasive.
Yeah.
So we found like for the elbow, if you use those, they rub on the capsule and they're abrasive. Rather than like proline or nylon, those are smoother, right?
What number of the proline, what number of ethylene you are using, either 40, 50, 60, depending upon your vision, your availability of this setup, whether it is good. Even microscopic repair, they people do in an excellent way. But the thinner suture you use, the strength cannot be achieved. So the thickness of the suture, as well as technique, strength, and early mobility, all the factors are very important.
Yes. Thank you, Prof.
Thank you.